Obstetrician Maternal Fetal Medicine Subspecialist, Dr. Muhammad Adrianus Bahnas, Obstetrician Maternal Fetal Medicine Subspecialist, Dr. Eric Edwin, Obstetrician Subspecialist Maternal Fetal Medicine, Dr. Wisnu Prabowo, Obstetrician Maternal Fetal Medicine Subspecialist. And all of the option and pediatric RSDM staff, affiliate staff of obstetric and gynecologists, option and pediatric resident, co-assistant, and the participants who are present here today. Welcome to 11 Maret University International Collaboration Lecture with the theme Early Onset Fetal Growth Restriction and Future Treatment Option, a collaboration between UNS Medical School and Monash University. To open today's lecture, first let's hear the opening speech. Without further ado, let's immediately start this event that will be moderated by Dr. Lini, obstetrician. Participants are expected to fill out the attendance form using the link provided in the chat box. Dr. Lini, obstetrician, as the moderator, will now take over in guiding today's event.
Okay, thank you from the MC. Today we will directly to main event of this collaboration, and we have two speakers, one from Monash University, Dr. Kirsten Palmer.
Putus ya?
Enggak. Hello.
Assalamualaikum, Adi.
Hello.
Assalamualaikum.
Dr. Kirsten Palmer. Can you hear my voice?
Yes, I can hear you.
Okay, thank you. Allow me to introduce myself. I am Lini Astetri. Today will be the moderator of this meeting. Maybe Dr. Kirsten Palmer, I would like to read about Dr. Kirsten Palmer. She's an obstetrics and gynecology specialist, maternal fetal medicine subspecialist. She is a clinician researcher, a maternal fetal medicine subspecialist, and heads the maternal fetal medicine unit at Monash Medical Center, Monash Health. She is a senior lecturer with the Department of Obstetrics and Gynecology at Monash University, where she heads the maternal and perinatal medicine translational research group. Contribution to field of research, she currently leads a world-first large multi-center clinical trial exploring the use of melatonin for fetal neuroprotection in pregnancies complicated by fetal growth restriction. And international research collaborations, research seeks to translate promising new therapeutics into the clinical setting with a particular interest in disorders of placentation, such as preeclampsia and fetal growth restriction. She has developed a collaborative network, both nationally and internationally, undertaking research that extends from exploring the pathophysiology of these disorders to better inform new clinical advances through clinical trials to assess the true potential for improving clinical outcomes. She has many publications, and her recent publication about comparison of circulating total SFLT1 to placental specific SFLT1 E15A in women with suspected preeclampsia, and the second, maternal and neonatal complications in women with medical comorbidities and preeclampsia, and alignment of national COVID-19 vaccine recommendations for pregnant and lactating women, and many more. Maybe Dr. Kirsten Palmer, you may begin your presentation. You have about 1 hour for your presentation and discussions.
Are you able to see my slide reasonably well there?
Yeah,
Great.
we can see it clearly here.
No worries.
Kirsten,
Now,
I think you're using two
apologies, I've had.
screens.
Sorry?
I think you're
Could
using
you
two screens,
please-
so if you can swap with the other one, but it's all right. We can see two images. Yep, this better.
Yeah.
Okay,
Better.
good.
Thank you.
Perfect. Now, my apologies. I was just told yesterday that you wanted just a half an hour presentation. So I've just got about a half-hour presentation that I've put together for you. But certainly I'm very happy to answer questions and speak for as long as you would like.
Yeah, it's okay. You have an hour.
So thank you so much for inviting me to come and speak to you today around early onset fetal growth restriction. I was asked to speak a little bit on the diagnosis of fetal growth restriction and talk through some of the future treatment options that exist, both internationally, but also what we're undertaking here at Monash Medical Centre in Melbourne. So I just wanted to start really with an overview again of fetal growth restriction itself. Many will be familiar with the fact that fetal growth restriction is really an end diagnosis, and it doesn't necessarily explain the cause that's enabled us to arrive at that diagnosis. The vast majority of babies that are small are due to placental insufficiency, so a placenta that's failing to deliver the oxygen and the nutrients that the fetus requires to reach its optimal growth potential. But we can see a raft of other causes for fetal growth restriction, including infectious causes, commonly conditions like cytomegalovirus and congenital syphilis can be major contributors. We can see underlying chromosomal or genetic issues, and we know that with babies particularly that are impacted by early onset fetal growth restriction, around 20% of them may actually have an underlying genetic contribution as to why they are small. And then we can see structural issues that might lead to that end diagnosis of fetal growth restriction. And this is particularly common with babies that might be impacted by skeletal dysplasias or disorders that affect the anterior abdominal walls, such as gastroschisis and omphalocele, that are going to impact on their measurement of abdominal circumference. Here in Australia, fetal growth restriction affects around 1 in 12 pregnancies, and this equates for us around 25,000 Australian babies every year. But we know globally that this is estimated to impact over 30 million babies every year. And this is a major issue because not only is fetal growth restriction a major antecedent and cause of stillbirth, but also through the developmental origins of health and disease, we're beginning to understand that the impact of fetal growth restriction during in utero life sets someone up for poorer health outcomes across their lifespan. And so when we go on to think about the diagnosis of fetal growth restriction, particularly early onset fetal growth restriction, which I'm focusing on today, the mainstay through which we can diagnose it is utilizing ultrasound. And so obviously this is through taking a range of measures of the fetal head circumference, biparietal diameter, abdominal circumference, and femur length to enable us to calculate the estimated fetal weight. And then ideally using, population appropriate charts, we're then able to plot that estimated fetal weight for gestation to give us an idea as to what the centile is. In terms of the current diagnostic criteria, it is always nebulously referred to as a fetus that fails to meet their genetically predetermined growth trajectory. And as a clinician, this is an incredibly unhelpful definition of fetal growth restriction because we do not know what that child's genetically predetermined growth trajectory is to help us in determining care. So a number of years ago, a Delphi consensus was undertaken, led by Sanja Gordjian out of the Netherlands and Wessel Gansevoort. And they showed from that Delphi consensus that the appropriate definition of early fetal growth restriction for use clinically is in a baby that's identified as small before 32 weeks gestation. This is really just focusing on those 70% that we know are small because of placental insufficiency, where it's utilizing that abdominal circumference or their estimated fetal weight of less than the 3rd centile, or where it may be less than the 10th combined with abnormal uteroplacental Dopplers, either in the uterine artery or the umbilical artery. And so not only do we need to use ultrasound to be assessing the fetal size and fetal growth, but we also need to use ultrasound to assess the uteroplacental and fetal circulations to actually determine, is this baby pathologically small? And this is where understanding the physiology of the fetal circulation and how it relates to the uteroplacental circulation is really crucial. In terms of then how we can use ultrasound to interrogate this and help to confirm, is there fetal growth restriction present or not, we're able to look at the umbilical artery blood flow. Now, remembering that this chiefly tells us about placental resistance and how the placenta itself is functioning, looking particularly at the pulsatility index and the end diastolic flow to get an idea about, is there increased resistance or are we starting to see a loss with absent or reversed end diastolic flow to really indicate significant placental insufficiency, placental disease. And this is mainly helpful in this early onset growth restriction population, remembering that the umbilical artery Doppler becomes more unlikely to get an abnormal reading later in gestation. As we get placental insufficiency and the fetus is then needing to adapt to the environment that it's in order to survive, we start to then see alternate changes elsewhere within their organ systems. So we now see this redistribution in blood flow where the fetus then preferentially directs blood away from the less important organ systems such as their kidneys. And we see this with then a reduction in the amniotic fluid volume or their deepest vertical pockets with reduced renal perfusion, reduced urine output. And this is occurring in this state of increasing fetal hypoxemia, where they're then sending the most nutrient and oxygen dense blood to their most crucial organs, being the brain, and the heart and the adrenal glands. And so with this then interrogating our middle cerebral artery Doppler, we can start to see a change with redistribution in blood flow indicated by a middle cerebral artery pulsatility index below the 5th centile. As the fetus becomes more compromised, we will start to see evident myocardial ischemia. And we can see this through utilizing the ductus venosus waveform. As the fetus becomes increasingly hypoxic, we'll see a fall in cardiac contractility with myocardial ischemia. And with that, we'll start to see an increasing pulsatility index within the ductus venosus waveform, and sometimes a absent or reversed A wave within the ductus venosus. And so it's utilizing all of this information not only to confirm the diagnosis of fetal growth restriction, confirming that placental insufficiency is the cause of that, but also utilizing these various waveforms to help to then guide us in the timing of birth. And we can do that because a large number, not all, but a large number of fetuses will follow a fairly gradual pattern towards demise in the setting of significant placental insufficiency. And so you can see that in using this information, this not only helps us to diagnose fetal growth restriction, but enables us to hopefully keep that fetus in utero for as long as possible, whereby we're trying to prolong gestation to minimize the really significant issues that happens for babies that are born profoundly premature, but trying to make sure that we deliver them before they unfortunately succumb to the expected process, which is stillbirth in this circumstance. So certainly for babies before 32 weeks, certainly for us here at Monash, we will often be pushing them to quite significant Doppler derangements before we deliver them, such as seen here with reversed end diastolic flow in the umbilical artery, complete MCA redistribution, and not always pushing them to a reversed A wave in the duct, but certainly getting close to it. Now, the challenge is that this is really the crux of what we're able to currently achieve as obstetricians. But we know that during this course, the fetus is actually suffering still significant end organ damage during life in utero. And so currently we're really just trying to trade off these very crude outcomes of the potential death and disability of extreme premature birth to the death of the stillborn baby due to severe growth restriction. But we don't currently have any treatments that can otherwise improve the outcomes for babies affected by fetal growth restriction. And so we know that for survivors of fetal growth restriction, that unfortunately at the time of birth, they are born with fewer cortical cells within their brain that show delayed myelination. They have reduced total brain volumes and grey matter volumes that sets them up for an increased risk of neurodevelopmental disability across their lifetime. They're born with fewer cardiomyocytes and smaller coronary vessels within their heart, increasing their lifetime risk of hypertension and cardiovascular disease. They've got an increased lifetime risk of diabetes with fewer beta islet cells within their pancreas, and also of progressing to end-stage renal failure with fewer nephrons within their kidneys. And so we know that particularly when we focus on the brain, that fetal growth restriction then combined with significant preterm birth are major risk factors for subsequent cerebral palsy. So when we think about what kind of treatments may be possible to try and mitigate these effects, it's about understanding that process that is underpinning fetal growth restriction. And when we focus on placental insufficiency, we know that with this, we have a placenta that's got impaired remodeling of the uterine arteries and the uterine spiral arteries. And this leads to persistent state of hypoxia reperfusion injuries throughout that placental bed. We see higher rates of oxidative stress within the placenta, leading to the production of reactive oxygen species that impact not only within the placenta itself, but are also able to cross over into the fetal circulation. Now, reactive oxygen species are capable of causing direct cellular injury. They cause widespread DNA damage and lipid peroxidation. And this happens not only within the placenta to continue to perpetuate abnormal placentation, but within the end organs of the fetus, producing the damage that underpins much of those long-term adverse health outcomes that I've just mentioned. And so when we're thinking about therapeutics in development, there are therapies that are being developed that are focusing on trying to actually improve growth of the fetus in utero and actually solve the underlying problem of fetal growth restriction. And I'll go touch briefly on some of these, which is tadalafil, which is a phosphodiesterase inhibitor, as well as vascular endothelial growth factor gene therapies. And then we've got other approaches that are more trying to focus on minimizing the organ damage that results as a downstream consequence of placental insufficiency. And these are then looking at chiefly antioxidant therapies such as melatonin, which I'll go through in more detail, and polyphenols. So when we think about trying to enhance perfusion into the uterus, there are already approaches that people will use in the clinic, and these are chiefly treatments such as aspirin, which we know can reduce the risk of fetal growth restriction by around 10%. Heparin has not been shown to overly make any difference in terms of outcomes, but may be appropriate in certain select patient groups. And so the main ones that have been trialled, many will be familiar with sildenafil citrate and the STRIDA trials that were undertaken that were unfortunately negative in terms of showing any benefit in fetal growth and with the suggestion of potential fetal harm. But certainly the phosphodiesterase inhibitors remain an attractive potential in terms of helping to affect smooth muscle relaxation within the vascular bed to try and help to improve blood flow through to the placenta. And this can also be something that may be able to be potentiated through utilizing gene therapy with the introduction of vascular endothelial growth factor. This is essential for optimizing nitric oxide synthase production, activation and the production of nitric oxide, which is another potent vasodilator. Now, whilst the sildenafil strata trials were unsuccessful, a group in Japan have been also doing trials of tadalafil, and they were undertaking the TDAFA trial at the time of the Dutch strata trial. So unfortunately, TDAFA was finished early when the outcomes of the Dutch strata trial were released. But with the recruitment that they had achieved up until that point, they were able to show a substantial reduction in the tadalafil exposed group in terms of fetal and perinatal mortality rates compared to what they saw in their placebo or conventional treatment group. When they've looked at their data in a little bit more detail, they did recruit patients between 20 weeks to 33 and 6 from memory. When they looked at those that were born and diagnosed, before 30 weeks gestation, they were actually able to show that those that were exposed to tadalafil gained an extra 18 days of gestation before birth. And this is absolutely massive in terms of the benefit that this can provide in terms of reducing really significant risks of prematurity for those babies born early. And so on the back of this finding, the Japanese group has now progressed and have started recruitment for the TDAFA-2 trial. And so I think this will be really fascinating to see the outcomes in the years ahead. And certainly the preliminary findings from TDAFA-1 look incredibly encouraging. The other approach that is really being spearheaded by Anna David in the UK now for the last 18 years is looking at trying to develop a gene therapy for fetal growth restriction. And this is really looking at that core underlying developmental issue that has arisen way back at the start of pregnancy, where we know that the remodeling of the spiral arteries into the villus bed of the placenta is impaired. And obviously this is a figure from a preeclamptic placenta, but we know that the morphology in a growth-restricted placenta shares a lot of similarities to the preeclamptic placenta. And so the hope is that with these shallowly invaded placentas, with the inadequate remodeling of the spiral arteries, if through the use of VEGF gene therapy, we may be able to actually improve the blood supply through to the villus space, it could help to correct a lot of the issues with early onset growth restriction. And so with VEGF gene therapy, obviously the VEGF family is quite a large family. There's a range of different ligand subtypes, and there's also a range of different VEGF receptors that sit on the cell surface. In terms of the VEGF receptor type 2, this is the main receptor that's involved in really improving angiogenesis and vascular permeability. So this is really the target of gene therapy. The main two ligands that exist is VEGF-A, which is that yellow ligand, and then VEGF-D is actually the one that they're now utilizing and working up for the gene therapy clinical trials. And that's just because it has reduced off-target effects and a more predictable and directed effect. In terms of the gene therapy and what they're developing, they're looking at utilizing adenoviral introduction of the VEGF-D gene, which would be directly injected into the maternal uterine artery, and then through that acting to improve uterine perfusion to the uterus and placental bed. What they've been able to show to date in animal models is improved uterine blood flow with this approach and increased angiogenesis. And then also, really importantly, they have been able to show in both sheep and guinea pig animal models improvements in birth weight and improvements in organ development and size as well. Now, this has been many years in the making. The Everest trial is yet to commence human trials of gene therapy, but certainly the regulatory and ethics that need to be achieved to work towards this have now been achieved within the UK, and I anticipate that the Everest trial will likely commence recruitment in the years ahead. Now, the other key approach then is to actually look at fetal organ protection. And most of the work that's done to date has really focused on neuroprotection. In terms of the neuropathology that results from fetal growth restriction, we know, as I've mentioned, a large amount relates to oxidative stress, where you have reactive oxygen species going and causing direct cellular injury. But we also know that the result of the direct cellular injury then is also inflammation as part of the body's own response to tissue repair. Within the setting of fetal growth restriction, we've got a fetus that's continuing to be exposed to a state of chronic hypoxia and hypoglycemia. And it's through these multiple mechanisms then that we see the structural brain injuries that are occurring during fetal life that are then going on to contribute to the poorer neurodevelopmental outcomes that we see amongst survivors. In terms of one of the trials that's exploring avenues to address this, this was one that was just published last year, which is looking at polyphenols and using the antioxidant capabilities of these. This was a trial utilizing pomegranate juice and exposing mothers with early onset growth restriction to either pomegranate juice or a placebo. And this was a relatively small trial that was undertaken. And what they did was that they did Kitakori scoring on MRIs and functional performance. And they were able to show certainly a reduction in the proportion of offspring with any brain injury particularly, but also any injuries within the germinal matrix and white matter, more in the pomegranate juice or polyphenol exposed population compared to those that received the placebo. And so overall, this reduction in terms of any brain injury was around a 30% reduction, which is quite impressive. Now, there were numerous issues with this trial. There was a lot of issues with how it was undertaken, but it certainly provides some encouraging premise with a very, very safe product to explore further in future trials. The other work is the work that we're undertaking here at Monash, and this is looking at melatonin. And melatonin is a potent antioxidant. So when I talk about reactive oxygen species and oxidative stress, this is essentially the pathway that we're talking about. So with reactive oxygen species, we see the production of superoxide and hydrogen peroxide chiefly. And these are those reactive oxygen molecules that go and cause the direct tissue damage and cellular harm. Now, in terms of melatonin, the reason why it's such an attractive therapeutic is that it has potent antioxidant effects through both this indole ring within its structure that directly scavenges these reactive oxygen species, but also through indirect actions that melatonin has through binding to the cell surface receptors on host cells and helping to upregulate that cell's own innate defense systems against reactive oxygen species. And it does this through helping to upregulate a range of enzymes such as glutathione peroxidase and superoxide dismutase that help to also further counteract and neutralize those reactive oxygen species. In addition to its antioxidant properties, melatonin, however, also has anti-apoptotic and anti-inflammatory properties. And so through all of these processes, it's incredibly promising that it may help to minimize and reduce the structural brain injuries that underline subsequent neurodevelopmental impairment. And it was this very premise that led a group led by Professor Susie Miller at the Ritchie Centre here in Melbourne to explore melatonin as a neuroprotectant in a sheep model of fetal growth restriction. And so this is just some of her published data. And here what we're looking at is immunohistochemistry slides that have been taken from lamb brains following birth. In their control model, which you can see here in this first column, and then we've got our growth restricted model in this second column. In terms of the growth restriction model, it's a single umbilical artery ligation model that does produce lambs that have a birth weight around 30% less than the control population group. In this first row that we're looking at here, we're looking at CN-PASE staining, and this is a staining that helps to look at the oligodendrocytes within the brain. You can see that in the control lambs, we have these lovely organized structural processes here with quite significant darker brown staining, which really indicates more mature and organized oligodendrocytes. In comparison with the growth-restricted lamb model, it's much lighter in staining, and you can see it looks much more disorganized. And this really indicates a more immature oligodendrocyte and one where that structural development within the white matter tracts has been impaired. The second row now we're looking at just the density of myelin, and you can see that the density of myelin is reduced in the growth-restricted lamb brain. And then in these bottom two rows, we're looking at beta amyloid precursor protein staining. Now, beta amyloid precursor protein is a protein that chiefly just remains within the neuronal axons, and it's shuttled along the axon. When we can see the staining as you can as this brown stain in the growth-restricted lamb brains, what that indicates is sites of axonal injury, where the beta amyloid precursor protein has now been able to leak out of the neuronal axons into the surrounding microstructure. It's really quite significant injury. When these growth-restricted lambs, however, are exposed to melatonin during the pregnancy, we now see a return to a more organized pattern in their oligodendrocytes with improved myelin density and no evidence or minimal evidence of axonal injury within the white matter tracts. And when we look at this within specific areas of the brain, we can see that most of this benefit is occurring within the periventricular and subcortical white matter tracts, which are those areas of the brain that are most susceptible to injury and fetal growth restriction and most associated with subsequent cerebral palsy development. And so this is just an example of some of the preclinical science that has gone on to then inform the clinical trial that we're now undertaking here in Melbourne. And this is the Protect Me trial, which is exploring whether maternal melatonin supplementation in pregnancies impacted by severe early onset fetal growth restriction can improve neurodevelopmental outcomes amongst survivors at 2 years of age. In terms of the trial, it is a triple-blinded randomized parallel group placebo-controlled trial with the primary aim, which is the 2-year outcome of improving neurodevelopment in terms of the cognitive score amongst survivors of early onset growth restriction. But the trial also seeks to answer through the secondary aims whether melatonin supplementation in utero does have any impact on fetal growth or well-being. We're wanting to add to the data around the safety of the use of melatonin in pregnancy by looking at the rates of adverse or serious adverse events associated with its use. And we're also wanting to explore whether melatonin can help to reduce those rates of structural brain injuries using magnetic resonance imaging compared to placebo. Now, the trial did commence recruitment where I work at Monash Medical Centre back in 2019 and was fully funded at the end of 2019 with commencement of rollout of the trial in early 2020. Now, as you have also experienced, the joys of the COVID pandemic have had significant impacts on our ability to expand this trial over that first couple of years. But the trial is now active across 10 sites across Australia's eastern seaboard and within the North Island of New Zealand. And we're currently making progress with a range of other sites around Australia and New Zealand, where hopefully the trial will commence recruitment at a further 5 sites in the coming months. In terms of the trial itself, we're following babies throughout fetal life, infancy, and into their early childhood. In terms of recruitment, we are identifying and recruiting patients that meet that Delphi consensus definition of placental insufficiency growth restriction. So between 23 and 31 plus 6 weeks with a baby with an abdominal circumference less than the 3rd or less than the 10th with abnormal uteroplacental Dopplers. If patients are willing to be recruited and baseline maternal and fetal data utilizing bloods and ultrasound, and then they are randomized to receive either 10 milligrams of melatonin 3 times a day or a visually matched placebo. And they continue then that medication up until birth. To continue to add to safety data, we're collecting maternal blood around 48 hours after they've commenced treatment, and then again 2 weeks later, and then collecting their clinical ultrasound data every fortnight throughout the pregnancy up until birth. At birth, we're collecting maternal and cord blood data, and from many participating sites, placental samples as well. Then at term-corrected age, babies are undergoing a magnetic resonance imaging scan that includes diffusion-weighted imaging that enables us then, through liaising with colleagues at the CSIRO in Queensland, to undertake white matter tractography analysis to really assess whether there are any evidence of structural brain injury within the white matter tracts. At term-corrected age, and then again at 3-month corrected age, families then also undertake the general movements assessment, which is we're utilizing a phone-based app to support them with this, so they can take this from home, which is a 3-minute video of their baby awake and alert but not distressed, and observing for any fidgety or writhing movements as judged by a team that we're liaising with at the Murdoch Children's Research Institute here in Melbourne. And then at 2 years of age, families return for a full Bayley's 4 assessment and the infant toddler social emotional assessment as well, to really be able to gauge not only their cognitive development, which is our primary outcome, but also impact on language and motor development as well. To date with the trial, we have been able to recruit 134 out of the 336 participants that we are aiming for, and the 336 are really powered to enable us to hopefully see with confidence a 5-point difference on the cognitive domain of the Bayley-4. Now, ultimately, with all of this, our goal is to continue to improve the way that we diagnose and manage the fetus in utero, not only so that we can see them navigate fetal life safely to birth, and this is one of our trial participants arriving into the world, but also continuing to follow them along, because as obstetricians, our goal should be not purely seeing babies survive well until birth, but ensuring that they continue to develop into burgeoning toddlers. And this is another of our trial participant who had returned for their Bayley's assessment at 2 years of age. Obviously, for a trial like this, there's a huge number of people that are always involved in helping to make this actually happen, as well as their funding bodies. But thank you all very much for your attention, and very happy to take any questions you might have.
Thank you, Associate Professor Dr. Kristen Palmer, for the presentations. Very interesting presentation today. And next we go to discussions. We have panelists here. Let me introduce to you one by one. First, we have Professor Dr. Sri Sulistiawati, Obstetric and Gynecology Specialist, Maternal Fetal Medicine Subspecialist. And the second is Dr. Muhammad Adianes Bahnas, Obstetric and Gynecology Specialist, Maternal Fetal Medicine Subspecialist. And then Dr. Wisnu Prabowo, Obstetric Gynecology Specialist, Maternal Fetal Medicine Subspecialist. Please, for the panelists, you may, if you have comment or questions to Associate Professor Dr. Kristen Palmer. Prof. Sulis, or maybe Dr. Adrianes?
Okay. Me.
Prof. Sulis?
Thank you. Yeah. My voice is clear. Dr. Palmer, I hope you explain Suaranya terdengar.
Sorry, I'm having issues just with the sound.
Okay, I repeat. I beg of you to explain which one is the best for early-onset IUGR screening among the following, like maternal risk factor, body mass index, high fundal uterine, growth curve, ultrasound like color Doppler, biomarker, and chromosome analysis. Which one or maybe again the diagnosed together. And the second, antioxidant, the treatment of choice for IGR if the causes is oxidative stress, such as preeclampsia. What if other causes such as malnutrition, chromosome anomaly, and maybe disease of the maternal? Antioxidant is still relevant to IUGR therapy. Thank you.
Thank you. Can I just clarify, I understood the question properly. Was it just how do you go about determining between those various different causes of fetal growth restriction, which is actually the contributor? And then if it is an alternative cause of growth restriction, do these therapies that help to minimize damage from oxidative stress, I think that they're going to provide any benefit in those alternative conditions? Was that right?
Right.
So I think that is in answer to the first part of the question, I think that's where there is that importance of that global assessment in terms of maternal history, the family history, the history of any family conditions that run in the family, the parents consanguineous at all, which is obviously going to increase the risk of recessive contributors. It's also, were there any issues around infections in terms of their antenatal serology, antenatal screening that might start to point towards conditions such as infectious causes as to why this has happened, but also the circumstance with which the patient is seeing you in. Do they have any hypertensive disorders that have arisen in their pregnancy? Do they currently have preeclampsia? And we know that 4% of women with early onset preeclampsia will also have concurrent FGR and vice versa. So, it's starting to get that a priori risk from that history to start to indicate what might be going on. And then in terms of the actual assessment of the fetus itself, we can see features there that might help to start to indicate for us, particularly, if there are short, long bones, that's going to start to indicate potentially a more genetic cause of the growth restriction, evidence of any calcific changes that might indicate more an infectious cause, or hydropics features in collaboration with that. Whereas if you're getting abnormalities in the uteroplacental Dopplers, it's much more indicative of a placental cause. Obviously, a large number of babies that we will pick up as small are actually physiologically small, and they're not pathological at all. And we have the ability to cause significant anxiety and harm, I think, to the patients that we care for by making them think that there's always a pathological process at play. So I think that it's also important that we remember that there can be the constitutionally or physiologically small fetus. And that's where it really is about that ongoing continuity of care and follow-up, because that will be something that becomes more apparent with observation over time in terms of the growth trajectory as well of the fetus. So I think just as a broad approach, that would be my recommendation for the first part. We would generally routinely aim to send off at least CMV serology. Unfortunately, we do have a syphilis epidemic happening as well in Australia at the moment, so we tend to send off syphilis serology as well. And then others would only be as directed on history and ultrasound findings in terms of looking for other causes in terms of an infection screen. In terms of discussion around a genetic cause, I think particularly for early onset fetal growth restriction, having that discussion about the possibility of an amniocentesis to actually send off for genetic testing is an important part of the discussion. But in terms of how strongly I would push that as an investigation to undertake would really depend on the history and the ultrasound findings to some extent. But I would recommend offering it to every patient that you see with early onset fetal growth restriction, because, you know, we have found a number of babies that have come back where fetal growth restriction has been the only presenting feature for trisomy 18, and they haven't had any other structural anomalies. And these are diagnoses that otherwise would have been missed until birth, most likely. And regardless of the management approach, often something that I hear many of the staff say is that they didn't want to offer an amniocentesis because the couple wouldn't consider termination of pregnancy. But I think it's really important to remember that it's actually purely about information gathering, and it's not about necessarily dictating whether a pregnancy should continue or should not continue. But it's also about enabling a family to be prepared for whatever genetic condition their child might have and the additional care needs that that child may have, so that they're emotionally as prepared as possible before birth. In terms of the second aspect of your question around treatments with oxidative stress and the benefits that they might have, I think at this point in time, we do not have any data to suggest that these treatments are going to provide benefit for alternate causes of fetal growth restriction. These treatments, I think, are only likely going to be helpful in the setting of placental insufficiency. But, you know, there are some conditions such as, you know, trisomy 13 that are going to increase your soluble FLT production that over time could actually still also be associated with placental insufficiency, where we may see some benefits, obviously not for the fetus in trisomy 13, but potentially benefits down the track as well in terms of minimizing risks to the mother.
Okay.
I hope that answers your question.
Thank you. Yes, thank you.
Okay, thank you, Prof. Sri Sulistyawati. Maybe another question or comments from panelists, Dr. Adrianes.
Okay, thank you very much, Dr. Lini. Good afternoon, Professor Palmer. It's nice to meet you here for the first time. And it's very interesting lecture that we all have here. And furthermore, we would like to have collaborations for the research and knowledge between the Monash University and 11 Maret University, especially in the term of maternal fetal medicine topics or perinatal topics. I think it will be very nice. I'm afraid I have a few questions for you if we are still having time here. The first one that I see from your slide, tadalafil, looks like quite promising to be given for resoluting the vascular perfusion in the placenta. But as I know from the previous research using sildenafil, the result is quite a bit worrying, as we know that the increasing happening of the pulmonary hypertensions, the problems in, and also the hypertensions in the neonates. So is there any difference between the tadalafil and sildenafil in the term of the action of the mechanism of actions of the drugs? Okay, that's the first one. And the second one, that's a very nice research from your side, Monash, and collaborations also with other maybe university in Australia and New Zealand. And I just want to ask you that there is so much regimen for antioxidant. Why you choose melatonin? There is a superoxide dismutase, or maybe you can use steroids, maybe low dose steroids, maybe methylprednisolone or other. Yeah. And the next question is about the neuroprotections also. we are also studying fetal neuroprotections by giving a magnesium sulfate in the perimeter time for delivery. So whether your research also including giving a magnesium sulfate just before the time of the delivery. And then the last one about the presentation that you have shown to us that instead of the fetal hypoxemia will causing damage to the brain, but the heart ischemia also matters much. So whether you also examine and assess about the heart of the sheep that you are using for the research after using melatonin, whether it is also giving a beneficial impact for preventing furthermore of the heart damage. Thank you very much, Professor Palmer.
No, thank you. And I'll do my best. I might need to ask you to remind me on some of those questions as I work through them. But I guess just to work backwards, if that's okay to start with, in terms of the impact in terms of the cardiovascular development, certainly the data that's come out of the growth restricted sheep model that they've developed within the Ritchie Centre does also demonstrate similar kind of cardiovascular issues that we see in human survivors of fetal growth restriction. The program in terms of assessing the role of melatonin in terms of helping as well with the cardiovascular development is a little bit behind where it was with the neurodevelopment, but is underway. And actually the preliminary data that they're producing is really reassuring and really encouraging that melatonin is also affording improvements in cardiovascular development and cardiovascular outcome. And so we're actually in the process of trying to put together a sub-study that will sit within the existing trial and also be able to actually explore cardiovascular outcomes in our trial population when they come back as well for their pediatric reviews and pediatric follow-up to be able to investigate that a little bit further as well. In terms of the other question that you raised around, there are many other antioxidant therapies that are also utilized. Why did we use melatonin? Well, certainly melatonin itself is actually one of the most potent antioxidants that exists. So if you compare it to other antioxidants that have been used in large-scale clinical trials like vitamin C and vitamin E that were being explored as preeclamptic therapeutics 10 years ago and shown to be completely ineffective, melatonin is substantially more potent in its antioxidant capabilities than vitamin C and E were. The other benefit to melatonin is that there is certainly wide-scale data available in non-pregnant adult populations, but also pediatric and increasingly neonatal populations as well, that show that it's very well tolerated. It has an excellent side effect profile, and it doesn't yet appear to be associated with any significant adverse events. And so for those reasons, it's a really attractive therapeutic because it's well tolerated. For us as well, it's available in tablet form. So for women, they can take it orally. As you know, fetal growth restriction is a global problem. It's also, I think, really contingent that we consider global treatment options that are available for that. And so it's cheap. It's not currently licensed or patentable. It's available in a tablet form that doesn't require refrigeration. And so for these reasons, it's going to be a much more available therapeutic option for people around the world. And also it crosses the placenta and it crosses the blood-brain barrier with ease. So through a mother taking a tablet, it's getting directly to the site that we need it to act on still within the fetus. And so as a fetal therapeutic, that's absolutely fantastic because you think about most of our existing fetal therapies and you're looking at very, very small centres in very select population groups around the world that are generally looking at fetal surgical approaches for a range of different therapies. So that makes it cheap, safe and widely available and effective, hopefully. So that was part of the benefit. If you compare that to other treatment options that you raised, such as low-dose steroids, well, we know that unfortunately steroids have a very unattractive side effect profile. They are associated with long-term use with quite significant maternal side effects. And for fetal growth restriction, you know, if we're picking it up at 24 weeks, we know, unfortunately, the vast majority of those babies will deliver generally within a few weeks of diagnosis. But our goal, if possible, is to get them many months before birth. And asking a mother to be on low-dose steroids and all of the side effects and risks then that come from that for weeks to months, I think is an unattractive treatment option. And then in terms of other neuroprotectants such as magnesium sulfate, certainly in terms of the trial, we're not interfering with their clinical management at all. So the utilization of steroids for fetal lung maturity and for reducing perinatal mortality, and likewise the use of magnesium sulfate for neuroprotection, that's part of our standard therapeutic management for any babies that we're delivering before 30 weeks gestation at the moment. And that may change, obviously, as well when the results of the Magenta trial come out, and that might shift up to 34 weeks once those results come out. And so that absolutely already happens. What we do is we just purely capture that data of did they actually receive magnesium sulfate or didn't they, so that when we come through to doing our statistical analysis on completion of the trial, we can factor that in and see were there any differences between our placebo and treatment groups. In terms of your other question as well about tadalafil versus sildenafil, you know, I think certainly my heart goes out to that Japanese group that were undertaking the tadalafil trial at the time that the Dutch Stridor was published, and I'm sure that that has caused significant anxiety and issues, and without a doubt it's set back their research program by a number of years. There are definite pharmacokinetic and pharmacodynamic differences between tadalafil and sildenafil. I am loath to actually say specifically what they are right off the top of my head at the moment, but from memory, I'm pretty sure that tadalafil's actually got a longer half-life than sildenafil. And certainly that might be contributing to the significant differences that the Japanese group saw with TDAFA versus what was seen in either the Australian, New Zealand, the British or the Dutch Stridor trials, none of which showed any benefit, obviously, for the fetus. I think the data that came out of the Dutch Stridor in terms of the pulmonary hypertension, you know, certainly my understanding of that was that, yes, it was weighted more in the sildenafil exposed group than the placebo exposed group, but there were also other underlying clinical parameters in those particular cases that may have contributed to that beyond the sildenafil alone. And certainly in both the UK and the Australian, New Zealand Stridor trials, those same findings were not seen. So, you know, I think I would be hesitant to completely close the door on phosphodiesterase inhibitors at this point in time in terms of their potential. And so it's heartening to see that the Japanese group have been able to actually get the TDAFA-2 trial up, and it'll be fantastic to see if they're successful with that or not. Now, I know that you did have another question in there, and my apologies that it has slipped my mind.
One more question about the using of melatonin, whether you will give to all of the fetal growth restrictions, I mean about the centile, all of the less than 10 centile, or only in a very severe less than centile, such as maybe less than 5 centile or 3rd centile, which one will get a benefit more?
Yeah.
Thank you.
So, so we don't know the answer to that question just yet. Certainly in terms of the trial, we're recruiting everybody before 32 weeks. So that classic definition of early onset growth restriction, we believe it will only be effective for those with true placental insufficiency. So really trying to capture that population as much as we can. So those less than the 3rd centile, but also less than the 10th centile with abnormal Dopplers. In terms of the trial, it is further stratified by those less than the 28 weeks versus, 28 and 1 to 32 weeks to see, because we know that in terms of that risk of future neurodevelopmental outcomes, it's poorer for those that are diagnosed earlier. So we are stratified in our analysis between those two gestational age groups, but we have also stratified our analysis for fetuses either with or without abnormal uteroplacental Dopplers, because we also know that for babies that do have abnormal uteroplacental Dopplers, they also are associated with higher rates of neurodevelopmental impairment. So I don't know the answer to your question just yet, but the hope is that on completion of the trial, we will have data that will help to answer that. If it looks promising in this very, very sick cohort that we're recruiting at the moment, the goal absolutely would be then to expand that out to the broader population, to also include the later onset growth restricted population, and to see, does it also make a difference for that population group?
And we are also will be very happy if we can join the research collaborations. If you need the center from Indonesia, this is 11 Maret University, very open and happy to join the research, and we can gather the patients also from the Indonesia. Thank you.
Sounds fantastic. And no, I would be extremely keen to collaborate. That would be wonderful.
Okay, thank you, Professor Palmer and Dr. Adrian. Professor Palmer, do you still have time for us?
Yep, no, absolutely.
Okay, maybe we next to another panelist, Dr. Wisnu Prabowo.
Okay.
If you
Thank
have
you.
comment or questions.
Thank you, Dr. Rugi. Good afternoon, Professor Palmer.
Hi.
Okay, I want to ask about your slide. There's about aspirin. Yeah, aspirin in the research about IGR. I'm interested on the therapy. In your set, also the detection of IGR start in 23 weeks gestational age. What about if the pregnant mother has a bad history that he pregnancy?
Atas dulu ya, Pak. Atas dulu ya.
Bad history, like IGR before, maybe preeclampsia. Can we give aspirin before 23 week gestational age, maybe prevent the IGR? Yeah, I want to ask. I want to know your advice. And the second question about therapy about herbal, maybe flavonoid or quercetin. Can we use the drug about to maintain autotherapy in IGR? Thank you.
Thank you. Sorry, the sound was just playing up with the latter part, so I didn't get the second question very clearly, but certainly in terms of answer to the first question around aspirin use, absolutely. So we know that the most benefit that aspirin is going to afford in the setting of placental insufficiency is starting at before 16 weeks gestation. So whilst for our trial, we are recruiting babies between 23 and 31 plus 6 weeks, the really brutal reality as to why we chose that lower threshold is that the trial has a primary outcome of neurodevelopmental outcomes amongst survivors. And we know that for those babies that we identify as growth restricted before 23 weeks gestation, such as at 18, 19, 20 weeks, very few of them will survive to viability and be born alive. And so we wanted to ensure that for the trial, we were still recruiting babies that had a chance at survival, which is why we've chosen the 23 weeks as our lower cutoff, because that is generally the gestation where we will be more offering the chance of early birth and intensive care. But that doesn't dictate at all what we do in terms of their clinical care. That's purely just around the research question. So absolutely, for those that are at increased risk of fetal growth restriction, such as previously having had a baby that's been born small, particularly with maternal vascular malperfusion as that feature on placental histopathology, absolutely, I would be starting them on aspirin before 16 weeks gestation. Obviously, the data that we've got, it's still a fairly mild to moderate benefit that aspirin affords. But for families that have unfortunately lost previously small babies at 21, 22 weeks, any benefit we can achieve them is a good thing. So certainly, yeah, absolutely yes to the aspirin. And I would generally start it between 12 to 16 weeks. In terms of your second question, though, I'm very sorry, I just couldn't quite hear that one.
About the flavonoid or quercetin in plants. Can we?
Sorry, an implant?
Recording in progress.
Prof. Palmer?
Yeah.
Yeah. Can you hear me clearly?
Yes.
Okay. Dr. Wisnu asked about the use of flavonoid.
Flavonoid?
Yes.
Yeah. Can we use this drug for the prevent the inflammation in IgA? Maybe can we use this?
It's a good question. I have to admit, I'm not overly familiar with the use of flavonoids in that space. So look, certainly that might be another really good avenue for research collaboration as well, in terms of exploring that within the growth restricted models that we have here at the Ritchie Centre.
Okay, thank you, Professor.
Okay, thank you, Professor Palmer. Maybe it's.
Can I have one more question? Because
okay.
I'm interested to know about the experience from Professor Palmer giving aspirin for the previous history, obstetrics history with the placental ischemia resulting in a fetal growth restriction. Whether you also combine with the low molecular weight heparin, such as enoxaparin, instead of only giving aspirin, if you have a patients with the clearly visualized placental ischemia in previous pregnancy by using a 2-degree scale and also Doppler velocimetry, which you can all the findings you can have there, and what will you do in the next pregnancy, whether only aspirin or giving also the low molecular weight heparin?
Yeah, it's a really good question, and you know, in all honesty, I think it's a really hard one to answer. Where you know, the evidence, it's one of those challenges, isn't it, of trying to take evidence from the clinical studies that have been done and try to apply that to the individual person sitting in front of you and the unique circumstances that sit within that individual patient. And I think that's where that art of medicine comes into it to some extent. I think certainly if you've got that evidence of thrombosis throughout the maternal vascular bed, I think that it is reasonable in a future pregnancy to consider the addition of low molecular weight heparin to aspirin. Generally, I would be aiming to also do antiphospholipid screening in a patient that has had, you know, that adverse experience of profound early onset growth restriction with thrombotic changes throughout the placental bed. And obviously, if that comes back screen positive for antiphospholipid syndrome, absolutely, they would benefit from low molecular weight heparin use in a future pregnancy. Ideally, I restrict it more to those that are antiphospholipid positive. But depending on the individual patient's circumstance, I may also use low molecular weight heparin if there's been thrombosis throughout that vascular bed and, you know, they're in their mid-40s and they don't have any living children, and, you know, it's something, well, you know, we know that it's safe to use, and if it does have any clinical benefit, then yes, I would.
Dr. Adrianes?
Thank you. Very clear and nice explanation. Thank you very much, Professor Palmer.
Welcome.
Okay, thank you, Dr. Adrianes. If Dr. Prof. Palmer, okay. Thank you for your lecture, Prof. Palmer, and the discussion today. It's very inspiring, but sorry, I think the time is up. Maybe we should finish this session. We're glad to have you join in this session, Prof. Palmer, and we look forward for our research collaboration or another lecture. Thank you.
Thank you so
Thank
much
you
for having me.
the panelists. Thank you. You may leave if you want, you have another thing to do.
Thank you so
afternoon.
much.
Can we
Thank
take a
you.
picture?
See you next
with
time.
Ms. Palmer? Can we take a picture with Ms. Palmer?
Oh, Prof.
Yeah.
Palmer,
Yep, sorry. Perfect timing.
could you please have picture first? Okay. Operator, please to take picture.
I've already taken. I've already.
Okay. This for the participants to open the video. Operator? Okay. Okay, please. Oh. I'm sorry, the signal. Aku nggak bisa. Nggak bisa. Nggak. Nggak connect. Udah nggak apa-apa. Okay, thank you, Prof. Palmer. Thank you for the lecture today. See you next time.
Thank you so much. Have a good evening.
Okay, thank you. Maybe we can continue to second speaker, Dr. Nutria. Dr. Nutria, belum unmute, Dok. Masih mute. Still mute, still mute.
Bisa terdengar dokter ini?
Yeah, sudah bisa, Dokter.
Yep.
Moga, Dok.
Yeah. I have to speak in English or maybe in Indonesia?
In English, please.
Iya,
In
Dok.
English.
Jawa.
In English because it is recorded.
Jawa mungkin ya. Kamu
Okay,
harus
thank
mundur.
you.
After a very brief, detailed, and amazingly complete by Prof. Palmer, so I would like to present about FGR in a maybe rather light topic. It's about the onset and maternal risk factor and also the neonatal outcome for the FGR. I'd like to share. Okay.
Calling has been.
Is it already show the slide?
Yes, Dokter.
Thank
Clear.
you. I'd like to begin my presentation still in English, right?
Okay.
Thank you. Yeah. As we know that FGR is the failure of the fetus to meet its growth potential due to a pathological factor, and most commonly placental dysfunction, as Prof. Palmer said, before. And worldwide, FGR is a leading cause of stillbirth, neonatal mortality, and short and long-term morbidity. And at present in Indonesia, we feel sad and sorry, but the effective treatment, there is no effective treatment except delivery. And for the problem is in Indonesia, FGR identification is still not optimal and no clinical test to predict the onset of FGR in late gestation. So that the lack of therapies to prevent and substantial rates of fetal demise or permanent neurological deficit arise from FGR. And then we have to manage the problem with early identification of risk factor of FGR to reduce morbidity and mortality of perinatal, and also increasing knowledge of understanding pathological mechanism of subtypes FGR for tailoring therapies to prevent or treat FGR and reduce brain injury, and developing approach to increase the intervention, newest of the recommendation for timing and mode of delivery, and correct the surveillance, antenatal management, and timing of delivery can improve fetal and neonatal outcome. Before, maybe we can refresh about the difference between FGR and SGA, because the FGR cases often overlap with SGA. The FGR fetus fails to achieve its growth potential, this term that used by obstetrician to describe a pattern of growth over a period of time. And it has a high risk poor perinatal outcome, with the hemodynamic disturbance as fetal adaptation to undernutrition, hypoxia, or placental insufficiency. But the SGA, with the infant weight less than 10 percentile or more than 2 SD below mean gestational age, this term for SGA is used by a pediatrician to describe a single point of growth curve. So maybe we can call it healthy but small. And usually its absence of pathological process is 70%. The problem, the diagnosis is based on the estimated fetal weight below the 10 percentile. The less sensitivity because it's failed to diagnose if there is a developmental delay, but the fetal weight is not less than the 10 percentile. And FGR detection is how we can differentiate between the FGR and versus the SGA. And we can establish early diagnosis. FGR can occur in preterm, term, and postterm babies. Disparity of more than 2 weeks, we can call it with mild FGR, and more than 4 weeks is we can call it severe FGR. And the major concern is preventing the IUFD, perinatal brain injury, and severe intrapartum fetal distress. And the main is timely identification is difficult but crucial for proper management and favorable neonatal outcome. The incidence in Asia is 9,248 case of FGR, and in Indonesia, this is also high, 30 until 40%. It's 19.8% of FGR cases. And the average prevalence of for-center maternal and child health was 4.4%, with the highest prevalence is in Sarjito Hospital, 6.44%. And in Jakarta, FGR prevalence rate of 40% in low economic group, and in the upper middle class is 5%. And it is still high mortality rate. FGR in Indonesia is 5.4 per 1,000 live birth. The etiology may be from the maternal and then the fetal and also the placental. And then the classification, maybe we can differentiate between the depend on the relative size of head, abdomen, and femur. We divide it into symmetrical or type 1 and asymmetrical or type 2. The symmetrical is 20% and asymmetrical is 80%. And both of them, we can use the term of symmetrical, asymmetrical. In symmetrical, it's affected very early in phase of cellular hyperplasia, most caused by structural or chromosomal abnormalities or infection. Usually it's toxo, rubella, CMV. And asymmetrical is 80% affected in later months. It's in cellular hypertrophy phase. Then often caused by maternal disease extrinsic to the fetus, And disease alter fetal size by reducing uteroplacental flow or by restricting oxygenation and nutrient transfer or by reducing placental size. And its preferential shunting of oxygen and nutrients to the brain. We can see from the picture the differentiation about the symmetrical IUGR and asymmetrical IUGR. And the next classification is early onset and late onset. The early onset FGR is usually more severe with high risk of fetal morbidity and mortality associated with abnormal umbilical artery Doppler, and the underlying placental pathology is frequently similar to the early onset preeclampsia. So it is strong association with the preeclampsia, it's about 50%. And early onset FGR is usually easier to detect. But the main problem is the management, because how we determine the optimal balance between the opposing risk and stillbirth and also the prematurity. For the late onset FGR, it's more common, and the prevalence is 5 until 10%, usually mild, and less associated with preeclampsia, normal umbilical artery Doppler, and abnormal cerebroplacental ratio. And the diagnosis relies on brain sparing effect with the low resistance flow in MCA, and umbilical artery and ductus venosus Doppler studies is normal. The late onset FGR is less predictable, and there is a risk sudden decompensation and also stillbirth. So it's about the graphic in early and late onset FGR. We can, in this graphic, we can see the from the placental disease and compensated hypoxia until the serious injury, until the death. The FGR, not only for gestation at onset, but also for clinical manifestation, pattern of fetal deterioration, association with hypertensive disorder of pregnancy, and severity of placental dysfunction. And now we get to the risk factor. As we know that a lot of risk factor for the FGR, from the low socio and economic environment, family history and stunted fetal growth, also poor obstetric history, low weight before and during pregnancy, previous history of FGR, history of chronic disease, and then antiphospholipid syndrome, maternal hypoxic state, history of taking certain types of drug, placental abnormality, and also multiple pregnancy. So the risk of delivering FGR baby is higher for the woman with chronic hypertension, preeclampsia, asthma, overdiabetic, anemia, gestational diabetic, low pre-pregnancy body mass index. And we have research in our hospital in Dr. Muardi and 11 Maret University about study comparison of risk factor between early onset FGR and late onset FGR. The result is from the maternal age. We have age less than 20 years have a greater risk of late onset, and age more than 35 years have a lower risk of late onset. So the late onset FGR mother have a younger age. It's similar with the study from Lubrano et al. In 2022 and Muhihi et al. At 2016. And the party, we have a result that multiparous women have a higher risk of late onset FGR than primiparous women. So the multiparous mother, especially grande multiparous mother, tend to have older age and degenerative disease. So it makes that higher risk of late onset FGR. From the basal metabolic index, underweight tend to have a greater risk of experiencing early onset FGR, and overweight has a greater risk for experiencing of late onset FGR. Mothers with BMI less than 18.5 tend to be diagnosed with early onset because it's insufficient nutrition obtained by the fetus during pregnancy affect the fetus weight. And the maternal profession, we indicate that mothers who work during pregnancy have an increased risk of experiencing early onset FGR. It can explain with the working mom having a stress factor that nutritional intake consumed by the mother is not sufficient. Calories for the fetus are reduced because it's depleted due to the work. And from the preeclampsia, mothers with a history of preeclampsia have a greater risk of FGR early onset, And the incidence of preeclampsia was associated in the previous slide. We also state that early onset FGR is strongly associated with preeclampsia. From the hypertension, mothers who have history of hypertension have a greater or higher risk of experiencing early onset FGR. That hypertension in maternal risk for early onset is 33%, which associated with placental vascular malperfusion. The next is anemia. Mothers who do not have a history of anemia have a lower risk of being diagnosed with late onset FGR. From the study of Ganju in 2020, 68% of mothers with late onset FGR were anemic. The anemic condition, it can be disturbed nutrient transport and impair placental adaptation due to low hemoglobin in the mother. And for the diabetic, mothers who have diabetic mellitus have an increased risk of experiencing early onset FGR. With the hyperglycemic cause oxygen difficult to enter the placental bloodstream and causes fetal hypoxia, then we can get to the FGR. From the asthma indicates that mothers who have asthma have a risk experiencing early onset FGR. It's the same pathology with the diabetes, that the lack of oxygen in the fetal blood impair the fetal growth, and it can happen to be FGR. But interestingly, there is no significant difference of the risk factor from maternal age, parity, BMI, maternal profession, preeclampsia, hypertension, anemia, diabetes mellitus, asthma between early and late onset FGR in Dr. Muardi Hospital. From the conclusion of maternal risk factor, we have to early screening. We have done to early screening for FGR, and whom to screen. From the conclusion that we have to screen for maternal demographic from the age, underweight, severe anemia, and then living in high altitude, or maybe from the environmental factors, air pollution, heavy metals, and heat. And also the medical condition with the chronic hypertension, DM, asthma, chronic disease, also SLA, and antiphospholipid syndrome. We can screen with the testing modalities from the simple with the symphysis fundal height, and then amniotic fluid index, Doppler of the umbilical artery with the NST, and also biophysical profile. And the next is we can discuss about the outcome associated with FGR. FGR increased risk of stillbirth, fetal compromise, early neonatal death, and neonatal morbidity. With FGR infant, health problem is cardiovascular disease and neurodevelopmental disorder. With the comorbidity is preterm and brain development. So the neonatal outcome in FGR is very depend on the neonatal death, asphyxia, sepsis, and also increased length of stay in intensive care unit and length of stay of hospitalization. We have a research study, comparison of neonatal outcome between early onset and late onset fetal growth restriction in Muardi Hospital. We have 121 samples for 2 years, 25 early onset and 96 late onset. With the result, neonatal death, there is a significant difference of perinatal death between early onset FGR and late onset FGR. With the odds ratio is 3.86, that the early onset FGR group was 3.869 times higher incidence of perinatal death than the late onset FGR group. It's similar with the systematic review of 2,895 pregnancy with early onset FGR, which is 355 or 12% experience antenatal death and 190 or 8% experience in neonatal death. The most common causes of mortality is severe placental insufficiency, chronic hypoxia, congenital malformation, congenital infection, placental abruption, umbilical cord prolapse, placental infection, and severe perinatal depression. From the neonatal asphyxia, there is no significant difference, but there is a 2.3% increase of neonatal asphyxia in early onset FGR compared with late onset. It explained with early onset FGR is associated with severe placental insufficiency, which decreases blood flow and gas exchange to the fetus, which causes perinatal asphyxia. In neonatal sepsis, there is no significant difference also in neonatal sepsis between early and late onset. But there was a 18.3% increase of neonatal sepsis in early onset compared with late onset. Is associated with Doppler abnormality and have a higher rate of neonatal complication, including sepsis. For the intensive care treatment, there is no significant difference in intensive care treatment between early onset and late onset FGR. And there is a 6.2% increase of intensive care treatment in early onset FGR compared with the late onset. And for the length of hospitalization, there is no significant difference also, but there is early onset FGR has a worse outcome and require longer length of hospitalization. From the study, we have a conclusion that there is a significant difference in perinatal mortality between early and late onset, but there is no significant difference of asphyxia, neonatal sepsis, intensive care treatment, length of hospitalization between early and late onset. So this is our job for health services to get the early detection, early diagnosis, appropriate management, and minimize morbidity and mortality. For the detection of FGR, we have the main screening risk factor, physical examination from the symphysis fundal height and ultrasound examination. Diagnosis we can get from the clinical, biophysical, and biochemical. And the symphysis fundal height is simple and easy to use. It measures in centimeter, maybe from the first line of health services in puskesmas or maybe in midwife. SPH measure in centimeters normally increases by 1 centimeter per week between 14 and 32 weeks. A lack of fundal height in 4 weeks, moderate FGR, and more than 6 weeks, it's conclude in severe FGR. Sensitivity of 58% and specificity is 87%. And we have to do the serial measurement. It's important for early detection for FGR. How about the sonography? Standard fetal biometry is assessment of head circumference, and then the biparietal diameter, BPD, abdominal circumference, and femur length. The headlock equation based on the three indicated head circumference, abdominal circumference, and femur length is greatest accuracy. So what we do if we get the sonographic fetal weight estimation, we have to exclude fetal anomalies and then evaluate the fetal size. And then we have to quantify liquor amni and assess the placenta, cord, and cervix. The first examination in 16 until 20 weeks should confirm gestational age and anomalies, diagnosis of the FGR type, and then we have to measure the head circumference per abdominal circumference ratio that elevated in asymmetrical FGR and FL per AC ratio elevated to more than 2.54 in FGR. The abdominal circumference is the most sensitive indicator with sensitivity is 95%. And the femur length, it is not affected in asymmetric FGR. FL per AC is 22 from 21 weeks to term. FL per AC more than 23.5, we conclude that it is FGR. The amniotic fluid, the volume is, if we find the volume vertical pocket of amniotic fluid less than 1 centimeter, it suggests of FGR. And also if we found the 4-quadrant technique, the amniotic fluid index less than 5 centimeter is suggests of FGR. With the placental grading, if we found the grade 3, the normally we found in more than 39 weeks with significant basal in basal calcification. we found chorionic plate interrupted by indentation, or we call it infarct placenta. Early progression to a grade 3 placenta associated with placental insufficiency. Growth chart, how to choose the best chart. Usually in here, we still use the Lupsen score, but actually the local or regional charts are likely to be the best to identify the 10% of infants at the highest risk. And we have to use the universal standards such as intergrowth 21st and WHO. Prefer growth standards over growth differences for the antenatal detection of FGR, and prefer growth chart based on sonographic estimated fetal weight, or EFW, over based on birth weight. This is very important for the growth chart. And how about the management of pregnancy with FGR? From the peri-viability, early viability, and NICU requirement. Absolute delivery indication independent of gestational age. So this one is absolutely have to deliver if the maternal status like a preeclampsia, repetitive FHR deceleration, sinusoidal tracing, absence of FHR, and variability with the late deceleration, or biophysical profile score is less than 4 from 10, and there is a STV less than 2.6 meter per second. The principal management is fetal surveillance and determination delivery. Perinatal outcome in early onset FGR, it's very important to optimization of perinatal or neonatology unit. So it is improved in a high level fetal medicine and neonatology unit. Delivery criteria is monitoring of umbilical artery, ductus venosus, and middle cerebral artery. Also, we have to expose about the CTG or NST. The monitoring, prevention of stillbirth by detection of fetal deterioration to irreversible compromise. We have to evaluate the fetal movement counting, fetal heart rate monitoring by CTG, this high sensitivity, loss of FHR or spontaneous decelerational final stage to fetal death, and computerized CTG detect the presence of STV, short-term variation in FHR, a marker of fetal heterogeneization with this acidosis and severe hypoxia. Ultrasound measurement of amniotic fluid volume, biophysical profile, umbilical artery Doppler, cerebral artery Doppler, and ductus venosus Doppler. I'm sorry, can I continue my presentation, Dr. Lini?
Yes.
Can
Already connect again. Continue.
I'm sorry, can you hear my voice, Dr. Lini?
Hello, Dr. Nutria.
Ya. Apakah sudah mendengar, Dr. Lini? Maaf, ini
Can
tadi
you hear
mati
my
lampu.
voice? May I continue the presentation? Yes. Sorry for the interruption because of the dead electricity.
Ya. Oke.
You may continue your presentation. Dr. Nutria.
Okay, is it clear? My slide? Can you
Yes,
see
I
my
can see your
slide?
slide. Yes, I can see your slide.
I already share my slide, my presentation.
Yes.
Okay. I continue my presentation.
Yes, please, Dr. Nutria.
Okay, the prevention of FGR in high-risk population with the lifestyle modification from the pregnancy planning, healthy lifestyle, optimizing medical condition with the optimizing body mass index, and also avoid smoking, alcohol, and drugs, and medical intervention with the aspirin, like Dr. Adri said before, and the adjunction of heparin and concomitant with the aspirin. This is the last slide. Final slide, the take-home message. FGR is associated with high
Dr. Nutria. Sinyal. Hello. Hello, Dr. Oh, Dr. Nutria hilang.
Lost of connection to Lini. Dr. Nutria, I think she lost
Hello,
of
Dr.
connection.
Lini, can you hear my voice, Dr. Lini?
Yes.
Yes, I can hear your
Yes,
voice,
Dr.
doctor.
I'm sorry. That's
okay,
my.
okay.
I'm sorry for the interruption.
It's okay, it's
Is
okay,
it
doctor.
okay? The connection.
Yes. Aduh. I think it's the signal, doctor. Your connection is interrupted.
No, my and here I use the phone, not the Wi-Fi.
Oh.
Is it okay
Oh.
with my
Nah,
signal
yeah,
now?
no, it's okay. No, it's okay. Tapi kok-
Mas Andi dong, tolong Mas.
Hello, doctor.
Yeah.
Maybe you can use the Wi-Fi again, doctor. I think the signal is
Yes.
okay.
I already used the Wi-Fi. Is it
Wi-Fi.
okay? My
Yeah,
signal?
it's okay now. Yeah, you may continue, doctor.
Okay. I'm sorry for the interruption, but maybe my presentation is in the final slide. Okay.
I need to take home message.
Yeah, take home message. FGR is associated with high perinatal morbidity and mortality. So the priority is establish the dating criteria and identify the identify the modifiable risk factor and optimize the maternal systemic disease. And also we have early detection and diagnosis, and proper management may reduce the associated perinatal morbidity and mortality. Thank you. Is my final slide. Thank you, Dr. Lini, for the attention.
Thank you,
and
Dr. Nutria, for the presentation. Very complete, very clear. Yeah. Okay, maybe from the panelists is Prof. Sulis. Maybe you still here in the meeting, or Dr. Adrianes, Dr. Wisnu.
Okay.
Please,
Dr.
Sulis. Please,
Yeah.
Prof. Sulis.
Okay. I think I want to ask about the when we should IGR be terminated? Because if we not sure if IGR maybe dangerous, like we maybe not IGR but like pregnant or SGR. Thank you.
Thank you, Prof. Sulis. Dr. Nutria.
My voice.
Yeah. Thank you, Prof. I'm sorry for the signal is not good in here. Yeah. When we terminate the IUGR of our FGR, maybe we have to differentiate first. It is FGR, pure FGR or small for gestational age. We can see from the Doppler, and we have to monitoring first. Maybe if we can differentiate with it is pure FGR, so we have to terminate.
Connection ya. Dr. Lini, I'm not here.
Hello, Dr. Nutria.
Ya, Dr. Lini. Maaf, Dr. Lini, ini kok saya mati ya. Di sini saya mau pindah nih.
Ke Anggrek 5 Mawon, Dok.
Ya, soalnya di sini kok mati-mati pada lampunya. Bagaimana, monggo Dr. Lini, maaf.
Izin dokter, maybe the question from Prof. Sulis.
Yeah. If we can differentiate between SGA and fetal growth restriction, we can examine from the umbilical Doppler artery and the cerebri media artery. If the cerebri media artery is the cerebroplacental ratio from cerebromedia and also the umbilical artery is less than 1, so we can know that the prognosis is not good. And also with the Doppler of ductus venosus, and maybe with the liquor amni, so the parameter is more than 1. If from the liquor amni and the Doppler there is a deterioration, so we can conclude that is a pure FGR, so we can terminate the fetal. Maybe like that, Prof.
Thank you. Good answer.
Thank you.
Okay.
Thank you, Prof.
Thank you, Prof. Sulis.
Yeah, thank you.
Okay. Okay. I think Dr. Nutria, thank you for your presentation. And we have the time is up already, almost 2 o'clock in the afternoon. So maybe we should finish this session, this meeting. And Maybe I will give time back to MC. Okay, I think thank you for the participation of this meeting. I'm sorry that we have to close because the time is up. Thank you, and I, Nini Astetri, as the moderator, and all of the. Okay, and thank you for the participation, and we are sorry if we have wrong or like in this event. We should meet again on another webinar. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for all.
Thank you, Prof. Thank you for all the participants.
Thank you, Dr. Nutria.
Inconvenient.
Sorry for the inconvenience. Sorry for the interruption of the signal. Thank you.
Izin ya. Assalamualaikum.
Waalaikumsalam.
Sami-sami. Selamat sukses semuanya.
Sampai ketemu di
Assalamualaikum.